Hello everybody, I'm Lisa Buckley and I'm with the Training and Education Core of the Injury Centre. I'm also an Assistant Research Scientist at the University of Michigan Transportation Research Institute. Thank you everybody for joining us in here today, and I'm hoping you managed to enjoy some of the food and the catering. For those attending remotely, a special welcome. So pleased that you've joined us, and if you have any questions during the event, type them into the chat box and we'll do our best to address them. First of all, I'd like to share some information about the centre before we get going. We're a CDC-funded, University of Michigan-supported research centre focused on injury prevention. We provide training and education opportunities like this one, plus some other courses in injury, internships, and fellowships. And we also work with the School of Public Health to have a certificate in injury. So if you have any questions about the certificate, let me know, or pop onto our website. We support practitioners and policymakers by providing injury prevention efforts information too. I want to make mention of our next lunchtime seminar, which is Thursday, March 10th. It's with Steve Rolio as an expert on sports concussion. So that one is March 10 at noon. So it'd be great if you could attend that one. And in April, we have Miko Yoshiyama and Rich Tolman to share information about dating violence interventions. But all our events are on the Injury Centre website. We'll also, later on in May, have a distinguished faculty event as well. So, as I said, please help yourself to food in the back and sign in as well. I'm pleased to get to the main event of today, to welcome Dr. Maria Muzik. I hope I pronounced that right, I'm sorry. Dr. Muzik is an assistant professor in psychiatry at UVM. Clinically, she focuses her work on mothers suffering from anxiety, trauma and depression during pregnancy and the postpartum period, and their infants and young children. She's the medical director of the U of M Department of Psychiatry, Women and Infants Mental Health Clinic, and leads the U of M perinatal collaborative care efforts to the community. Her research focuses similarly on the study of stress, trauma and mental illness in the context of childbearing and its influence on the developing parent-infant relationship and parenting. And today we're lucky that she's going to share some of that research with us. I also want to make a special mention of the press release that's come out today about some of her research. So please track that down and have a look at some of the exciting work that she's doing. We have some copies floating around too.
Thank you so much.
Special mention of that.
Thank you so much. I'm so pleased to be here, and first of all, I want to assure you I am not contagious anymore. I sound sicker than I am. I'm actually, other than the cough, I'm full recovered. So I'm pleased to be here and share some of my research work, but which is very grounded in my clinical interest. And you will see this as we kind of, I'm trying to tell you a story why I think that I and we all should be interested in this topic and support women who have had these experiences and are now parents. So first of all, in full disclosure, my worldview, we all have worldviews. I have one, and my worldview is that what happens early on, there's kind of this quote, the first 1,000 days, that what happens on, it's not a blueprint, it's not destiny, but it sets the stage. And it gets harder to change what gets early on in some way established. And we have now good data from epigenetics and, even earlier fetal programming. And I don't want to go into that detail because that's not what I directly do, but I read this stuff. So it's important. Pregnancy and postpartum is important. The other full disclosure is that I do believe that the parent-infant relationship is extremely powerful. So what even happens in pregnancy, fetal programming, epigenetics already early on, postpartum interaction with the parent, with an attachment figure, can modify even early established potential risks. And so, I don't know, are you guys familiar with the Stillface paradigm? Okay, so this is my first movie. The other thing is I'm into experiential learning. We will watch movies because I think that that's how we adults learn. Otherwise, we get bored. Even lunch cannot get you over that stuff. So this is actually, the Stillface paradigm is one paradigm that we use to really zoom in on the power of early interaction and how the dyad, whether it is mom or dad, how they are entrenched and intertwined, and how they're influencing each other. And are really how the infant is so dependent on this caregiver and the attention and emotional availability. And so this paradigm, and Ed Tronick, who developed it, will actually narrate. So I think this is really cool and a nice way to kind of get introduced to
babies this young are extremely responsive to the emotions and the reactivity and the social interaction that they get from the world around them. This is something that we started studying 30, 40 years ago, when people didn't think that infants could engage in social interaction. And the Stillface experiment, what the mother did was she sits down and she's playing with her baby, who's about a year of age.
I'm like a girl. Oh.
And she gives a greeting to the baby gives a greeting back to her. This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this. And then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, "Come on, why aren't we doing this?" Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions. They turn away. They feel the stress of it. They actually may lose control of their posture because of the stress that they're experiencing.
Okay. I'm here. And what are you doing? Oh, yes. Oh, what a girl.
It's a little like the good, the bad, and the ugly. The good is that normal stuff that goes on, that we all do with our kids. The bad is when something bad happens, but the infant can overcome it. After all, when you stop the still face, the mother and the baby start to play again. The ugly is when you don't give the child any chance to get back to the good.
Okay, so thinking about that still face paradigm, it really highlights, I think, how sensitive this diet is to kind of this co-regulation, and how actually sensitive and attuned an infant is to the regulation of the caregiver. The infant learns through the caregiver to see the world and learn about the world. And so if we mimic through the still face something like emotional unavailability in the presence of physical availability, which is depression or being zoned out, dissociated, drugged out, just not there, or just on the iPhone all the time. And then this is what the baby is experiencing. And as Tronick is saying, the good and even the bad is kind of the repair is possible. And in fact, diets are more in dysynchrony than synchrony. So the good news is we are all the time in dysynchrony with our babies, as we are with other adults. We are not always like attuned to their eye and gaze. It would be weird. It would even feel strange. There is research to show that that's not appropriate. But we make these repairs. So what happens if you don't have the repair? That's what he calls the ugly, is if there is a consistent, chronified unavailability, maybe in the presence of physical availability, but emotional availability. So, and that is what mental health issues, mental illness, depression, chronified use of substances, or high levels of anxiety, bipolarity, that's what it is about. So I want to introduce you to name change, and I got permission to see this, to show these videos, but this is one of the women that I worked with, and this is Jerry, and she does also the still face. This is just the first episode. And I'm just showing you a brief clip. Tell me what you see that's similar and that's different.
Pay attention to my mouth. Pay attention to me. Pay attention to mommy. Mommy needs some attention too, you know. Shake as fast as you can. Why do I think nervous dogs?
Okay, let's stop here. What did you notice? What is different? What? The baby is not engaged. The baby is actually looking away most of the time. So gaze is, it's the opposite. Instead of seeking mom in this, with Jerry, this baby is potentially overstimulated because mom is noticing that she's not engaged, that the baby is looking away and withdrawing, and so she gets more close. She gets even more into the baby's space, and the baby is then looking away. And you will see that actually, I'm not showing the whole Stillface, but during that Stillface episode, it's actually the baby looks at mom. It's just like, finally, it's a little bit more time to kind of relax. But that you notice that this mom is very aroused and notices that she is not being looked at. And she then says even, pay attention to me. Mommy needs some attention too. I am not visible to you. So she is hyped up. She's anxious. She's aware of it. She's feeling it. And yet that leads to some intrusiveness because she's like ruffling and that continues and escalates. And then maybe you heard one where she says something quietly, and we will come to that later, where the baby reaches out and, you know, the baby's just doing it. This is a 7-month-old. This baby doesn't have intentionality yet, and touches her hair, and she says, did you hear that, what she says? Ow, what are you hurting me for? Why are you hurting me? So again, there is an intentionality put into this that is about hurting. And so Jerry has had a rough life, and she is walking around, and we would talk about this. For her, the world is not safe, and she is projecting in part that this infant boy might be also unsafe. And the first quote is from her, and then I just put up some additional quotes. This is what moms with trauma tell you. They are worried. They are anxious. They want to be connected, and they are so worried about everything. I let you read it. Usually I read it, but given that my voice is kind of deteriorating, I think that the point being is, there's a lot of concern. Is the world safe? Are other people safe? Are other grown-ups safe? I don't want to have my child repeat what I went through. And then there is also, as you see in this, so this is another quote about just scare, scare, scare. Yeah. It's being worried about, is my child safe? Now yeah, it's here. No, must have taken there was another quote that I must have taken out because it was too much. Is also the worry: will I be a perpetrator? Will I be then too intrusive or abusive? I don't even know how to touch my child. Where's the line? Where's the natural line? So it's the worry about, is the world safe? Will I be a protector or will I be the perpetrator? So that's what women, and particularly women, tell us in those qualitative interviews. So there is where my interest came from. Being a clinician in peripartum, seeing in my own clinical work that there is mixed picture, that some moms who are struggling a lot and some moms who are remarkably sensitive and show actually a lot of resilience. And I wanted to get a more nuanced evaluation of parenting and mechanisms and that might be explaining these variations. What are resiliency factors? What are risk factors? And how can we support those? I mean, what is it that we need to do? Because just observing it is not enough. We want to intervene. And so with that, let me give you a little bit of prevalence data, why this is also important, because this is not rare. I mean, kids get abused. A substantial number of children experiences abuse. Substantiated 9 cases per 1,000, and it's very young kids. It's in infancy, and it's often neglect. This is predominant, but as you can see, neglect has a big impact to the infant's development of emotionality, self-regulation, and as if that is not established, that might lead to other problems downstream. And that often these abuse cases and fatalities are done by parents. And in those cases where the parent has been abused, him or herself, and women are actually more likely than fathers who have been abused, are then also the ones who are abusive to their children. So in such, there is some research to support that what the moms are worried that they have a greater likelihood. Women who have been abused also are not doing so well in terms of their relationships that they might establish. They have a higher likelihood to be re-victimized. And if you will hear Rich Tomlin, and you will hear about that. Who are the men that women pair up with, and who are the women who are in abusive relationships? So there is the likelihood for re-victimization. Pregnancy is not a protective time for women to be protected from abuse. And then women have a higher rate, if they have child abuse, they have a higher rate not only to be abused and traumatized again, but then also to develop mental health conditions. And to be comorbid, not only depression, but also PTSD together. Just like the last point is that once you had a diagnosis of PTSD, even because this is a waxing and waning illness, you might be better, you might be more likely to, when a new trauma occurs, to get worse again. And so to be re-experiencing these symptoms. And so when you look at prevalence rates, the prevalence of PTSD in general, in the general population in peripartum is not very high. It's like, 2%. There might be a peak if you had a traumatic birth, which many women do have. 20% of women experience their birth as traumatic. And that's a very subjective experience. And right now, there is some work here at the U to see actually what might be more objectifiable factors in terms of traumatic birth. But PTSD, even if traumatic birth increases temporarily, like acute stress disorder, 3%, over time it gets better, these symptoms. And the usual peripartum new onset PTSD would be like, 6 months out, 1%. And in general, there's a 10% lifetime risk for a woman to have PTSD. I'm not sure why this is always postpartum. I'm so sorry. But the rates get higher. The bottom line is the rates get higher the more risky environments you are. And the more you have added stressors, your rates might go up to 20, 30, 40% of PTSD in certain populations women who present to primary care who are from high-risk environments, or in teen clinics. I used to work at the Corner Health Clinic. High rates of PTSD and depression, comorbid, among these girls. So again, the question driving this research is, so what are the challenges? Is it the trauma? Is it the psychopathology that develops that might make you more impaired in your parenting? And what about genetic vulnerability by the baby? Is there also something that might be interacting with the parenting? And what about mom's cognitions? Are they important? Can they be buffers, or can they be risk factors? So I did this. This was my career development award, a longitudinal cohort study of women who had child abuse, and I followed them across. The main study was across the first 18 months postpartum, and I had basically 3 groups: women with child abuse who already had lifetime PTSD before they entered pregnancy, women who had child abuse but were resilient as they were entering pregnancy, and then women who were from the same neighborhoods. And this was the Southeast Michigan, so Ann Arbor, Ypsi, Detroit area, it was piggybacked on in part to another study, an R01 by a colleague, Julia Seng, who is in the School of Nursing and who had relationships here with the antenatal clinics here at University of Michigan, as well as Hutzel Hospital. And then we recruited also in the community through flyers. And as you can see, Julia followed the moms with the babies till 6 weeks postpartum. She's a nurse midwife. That's where her interested area is. And then I followed them postpartum mainly until 18 months. And we did a series of home and lab visits and phone calls. And the domains that we looked at was kind of repeated assessments of demographics and kind of at each time point, and trauma exposure, both the child exposure, but also ongoing trauma and other stressors and coping, mental health issues like depression, PTSD, but then also sleep, because we know in peripartum sleep is very important. And then similarly also for the infants and children. A lot about parenting, because that was my main interest. What are the attitudes? What are the representations? Kind of the fantasies about parenting and the relationship with the child, and also what are parenting behaviors. And then we did some biomarkers. We looked at stress reactivity. Is that a potential mechanism of risk transmission, as well as genetic markers in regards to these stress hormones. As you see from the demographics, this is not the economically most stressed population. So it's minority was quite diverse and overrepresenting kind of the general Michigan distribution, given that we were recruiting from a lot of African Americans from Detroit. But in general, there is some risk economically and education-wise, but it's not the most disadvantaged group of individuals in terms of socioeconomic. But still, it comes out as that is in all the that was a risk factor that independently added to parenting risk and psychopathology risk. So one of the questions was how do women do when they enter pregnancy and when they already had one-time lifetime PTSD? Is that going to be a risk for them? And how are they, in general, kind of sailing through this pregnancy, assuming that pregnancy might be experienced as something either stressful or joyful? So I wanted to know, will this per se be something difficult for them or something protective for them? And what you see is that when we then kind of mapped trajectories of symptoms, of PTSD symptoms across the pregnancy. So that's 28 weeks gestation, and before 28 weeks. So that's our first time point, then late pregnancy, and then 6 weeks postpartum. And these are all the women who already had a lifetime PTSD diagnosis. So this was the bigger Stacy arrow one from Julia Seng. These were 319 women total. It was pretty half-half. Some of them had high symptoms and some of them had low symptoms. And what basically predicted whether you started high, those two higher groups, the green and the yellow, was what your severity of childhood abuse was. The more severe childhood abuse you had, the more you were lifetime PTSD. Symptom load was higher. It was like an allostatic symptom load. And you already started higher in pregnancy with your symptoms. But even those women, and that was for me the big aha, actually they significantly dropped. And birth, which I thought would be like a peak maybe for them, because, anecdotally we hear, oh, when a woman has many women who have PTSD and had difficult experiences growing up, they have then very traumatic or difficult birth, prolonged or very short and painful. But for the big group, this was not a peaking of symptoms. Actually, they get better. So it's significantly lower postpartum than they started, as if. And now you can speculate, is it kind of entry to motherhood, this early period of motherhood is so connotated with positive? Is it that they get more support in this time, even in the context of high risk? When they get support around this time period, it decreases their symptoms. Or is it biologically because oxytocin and all these hormones are actually helping with anxiolytic? Oxytocin, we know, particularly when you breastfeed, that has an anxiolytic component. So that was a surprise. On the other side, what you do see is that one group really got worse. One group started low, and that group actually really got high and is almost reaching the ones who had very high childhood. So the difference between the light blue group and the green group in the beginning is that these light blue women did not have such a severe child abuse, but they did have child abuse and had PTSD at some point. But now we're actually doing quite well. But what happens across pregnancy is they are hit by trauma. They are hit by bad relationships, by difficult psychosocial situations, and that just hits them, and they are vulnerable. And they are going up in symptoms, plus they develop much more than all the other ones. Maybe that's just a measurement because that's what we measured. They develop high labor anxiety. They are worried about labor. And this we also measured work alliance with your provider, with the midwives, that did not distinguish. They did not feel more or less connected with the midwife, but it wasn't a protector. It wasn't a risk, but it wasn't a protector. So, and what also came out that when we then, and we had a smaller number that we could follow postpartum, but when you look at this group, the increasing group, these women at the end up with very high levels of depression. So by 6 weeks postpartum, they have now 50% also have postpartum depression. They are really sick. They're actually as sick or even sicker than the other ones. So they really got worse. And this group, and so this is actually my big spiel on this is preventable. If we would be screening, if we would be asking, if we would have if the obese would be supported in asking and screening and then knowing what to do, then we could help this group, and we would not have these kind of rising postpartum depressed women who still are breastfeeding. They're trying, but they don't feel connected. They're actually also the ones who have the least bonding, the highest bonding impairment. They don't feel connected. They feel, and I see this in clinic, a lot of women who say, I don't feel anything for this baby. And it takes weeks of treatment to develop this bond. We followed, so then I looked at what about the postpartum symptoms of PTSD and depression, and particularly, can we model this co-occurrence? Because given that we said that that's particularly more likely that they are actually these patterns of symptoms co-occurring, or are they crossing? Are there women who have only depression and not PTSD, or just vice versa? And what we found, and so this is now on the 198 of women that I followed, is actually these go together. Either you have both low, or there is this middle group where you are more depressed than PTSD over time, and then there is the third group, this pattern, where you actually have both depression and PTSD high, and it actually stays high. And in fact, as time goes on, you get even worse. And so that's the other big finding, or makes actually sense. As you know, infants are hard. And the first couple months in infancy are hard because the baby is not sleeping, mom is not sleeping, sleep is dysregulated, maybe breastfeeding doesn't go so well. But by 6 months, by 3 months, it already gets better because the baby gives you a social smile and there is some reward. By 6 months, many of these HPA axis sleep is regulated. And so it's easiest. And yet the baby is still a baby that you can shape and love and hug and cuddle, and they don't say yet, no yet. As toddlerhood comes, parenting actually gets harder, right? Because toddlers have a much more externalizing symptoms, and kind of saying no, temper tantrums are normative. This is the time of normative dysregulation, and that is harder. And so it's not surprising that those moms who particularly, so who are the moms in this group 2 and 3, these two patterns? Moms who had more, and it's really linear, moms who had more severe child maltreatment, more dissociation in early postpartum, in interaction, kind of felt subjectively had a lot of dissociative symptoms, who have ongoing trauma, and who have a lot of shame. So that is interesting for me. I'm getting really interested in the concept of shame. Moms who have been abused, women who have been abused, have a tremendous sense of shame, and self-loathing, feeling like, maybe I deserved it, maybe I did something to precipitate it, and it's this deep sense, and the higher this shamefulness, and we did questionnaires and we did projectives, and we have an interview, a so-called trauma meaning-making interview, where we asked the moms also questions like, what happened, and why do you think it happened to you, and what happened when was there a disclosure, and what happened, and who was there, and why do you think you were, it was you and in your family, and we code for content, but also for discourse, and then code for indicators of shame. So that would be posture, because you can see shame is a profound emotion that also goes along with special postures. So you can code for that, and the more we see these shame markers, the worse the moms are doing, and long term. So. Surprise, surprise, there are therapies for PTSD that's called acceptance and compassion therapy, ACT, right? It's all about get in touch with yourself and like yourself. It wasn't your fault. And you are who you are. Yes, it has shaped you, and yet it's not destiny. You can change, and you can be in control. So the question is now, what about parenting? So how do we study parenting? We already saw one example of how we study parenting. I mean, of course, you cannot live with someone and do reality show where you measure, their everyday life. But we are trying to get these kind of representative snippets of what they do. And so you could say we have average parenting tasks. So it's like low stress. Oh, play with your baby how you usually would. We have a set of standard toys. We come to the house. We say, okay, play with your baby as you usually, and we videotape 10 minutes. and assume that the first 2 minutes you are super anxious and you're like, oh my gosh, I'm on camera. But then over time you forget and then recode those second 5 minutes or the later part. So that's one way. Another one is to hype it a little bit up and to say, oh, okay, let's teach your baby something, right? And you can do something, teach your baby something age appropriate, or teach your baby something that's actually inappropriate. We don't say this to the mom, it's age inappropriate, but it's kind of stressing a little bit the system. So we ask the mom, teach your baby to put balls in a bucket. That's a 7-month-old baby. Can a 7-month-old baby put balls in a bucket? No, they can't. They might touch the ball and then drop it or put it in their mouth. They don't intentionally put the balls in the bucket. And they definitely do not stack blocks. So it's kind of a little bit pushing it. And see, what is the mom doing with this? What is the mom doing with this challenge that is, after a while she might notice this is totally nuts. I'm not going to do it. I'm just going to do it. And we just make it a game. Again, it mimics a little bit of reality, because in reality, if you have a baby and a toddler and you are shopping at Kroger and you have to do 5 things too, it's also inappropriate what you are supposed to do. You are supposed to do miracles. And you cannot get it all done. And sometimes you have to drop something, right? And so it's kind of mimicking the same idea that sometimes you make decisions because you realize it's not feasible. So we call these the more average parenting tasks that are even a little bit challenged. But then we have the Stillface, which is really a paradigm where we mimic, are you used to your mom being depressed? Because the research actually shows that a baby who is used to a mom being depressed, do you think is more stressed or less stressed when the mom holds a still face? Less stressed, because that's what my reality is, except the cortisol is chronically elevated. So they are stressed. They're just not behaviorally stressed, because it's kind of, I know what that is. So we did this with our moms, and we have this is data on 190 of our moms. And basically we modeled now in kind of in an analysis. So how is this now all hanging together? And so what you could see is, yes, this maltreatment history increased the likelihood for the mom to have depressive postpartum symptoms and PTSD symptoms. And yes, these are the moms who had maltreatment were more likely to have ongoing, more stress, kind of be in difficult relationships, be in difficult circumstances. So that was also related. And yes, we looked at parenting. And this is now parenting in free play and teaching tests. So the average parenting, we wanted to know are these factors impacting the average parenting? And how would that then relate to the baby sailing through a still face paradigm? Because for the baby, the still face is a stress. And as you could see in that video that I showed you, the baby was distressed. So you could assume the cortisol will go high. But in the reunion episode, the last episode where the mom re-engages, that's the task, right? Is the baby going to be re-soothed? Can the mom soothe the baby behaviorally and with cortisol? Is the baby going to have a decrease again of the stress response? And in general, we know from normative studies that all babies have a rise in stress, behaviorally and physiologically, and then they chill out. And that actually in this reunion phase, what is very typical, as you saw with this little girl, you see more negative affect as a kind of spillover, because the baby was just crying. Of course, this baby is still like, where were you? I'm mad, or I'm distressed. But the baby also shows positive smiles again. It's like the repair. It's the presence of that positive affect that has been actually shown as a positive marker to later, is this a safe relationship? Is this going to be a secure attachment relationship? So we looked at that too. And how would you build that knowledge? Oh, I can trust my mom in the reunion, that it's safe, that it's going to be okay, she's going to soothe me. It's based on the experience of your average parenting, right? The day to day to day. All these models in the baby's mind, they don't happen overnight. They're not innate. It's the experience, it's the lived experience of day-to-day life that is then shaping your anticipation. Will this mother soothe me or not? And even my biology knows that. Will I recover with my cortisol or not? And so basically what we see here is, one of the important things that you see here is that, yes, the more the mothers were positive parenting, and positive parenting defined as more sensitive, emotionally, behavioral sensitive, warm, affectively responsive, the more she was doing that in average parenting, so in the free play and teaching tasks, when we then did the Stillface, these babies were more likely to be behaviorally regulated in the reunion phase. They showed more of this positive, soothing behavior back to the mom, and the less were they elevated in cortisol. They didn't have such a cortisol reactivity, which we know now from other work that cortisol reactivity has a long term. If you are very highly reactive, and if you early on in life have an overload of cortisol all the time, over time, this axis might get, some people call it, you can call it overburdened. It starts to shut down, and then you have hypercortisolemia, and you see these high risk children who have been abused or who go through maltreatment or high adversity. They have flat circadian patterns and also flatter reactivity. So we saw that. So that's one thing that we kind of could show. Yes, this is important for the baby, what the mom does. The other thing that we saw, and it was that actually what was driving the effect more was depression. When we put it, I mean, in bivariate, it's both, but when you put them together, depression was actually more driving the parenting. And that is something that's actually consistent. And now kind of looking in the literature, again and again, when people kind of report on PTSD symptoms related to parenting, often they don't control for comorbid depression. And when they control, the effects might go away. And it makes in some ways sense. Why? I'm not saying that mothers, when they have florid PTSD symptoms or dissociate, are not impacted in parenting. But PTSD symptoms are more episodic, right? I might be okay. I might be maybe a little bit hypervigilant, but only when I'm dissociating, when I'm triggered, I might do something that's intrusive or be withdrawn because I'm dissociated. Whereas depression is more a persistent being, just not there. So depression has potentially, and again, other people talk about this, might be more pervasive in the impact on parenting than PTSD that might be more episodic in the symptoms. Does this make sense? So that was for me also something that I was like, oh, okay, that explains maybe where some of the moms that I saw in clinic who were PTSD, when I looked at them interacting with the baby, they actually looked okay, and the baby looked okay. And then that actually, when persistent, when a mom is really severely depressed, I had a much more concern for this diet. This is just to show you that, yes, there is a clear link, and we have found this and others have reported this, so this is nothing new, that parenting matters. Early parenting, how you parent in your first year of life. And of course, it's never ending. I have a 13-year-old. Never ends. But this early infancy, kind of establishing my worldview, these interactions, that sensitivity, that positive interaction, or being intrusive, over-controlling, or being hostile, rejecting, that matters. And if you have more of the good stuff, you have a secure attachment. What is secure attachment? It means now the child develops a representation of that parent. This is my go-to person. If I feel distressed, we measure attachment in times of distress, separations, pain, something that kind of arouses the child. Am I going to that attachment figure to get soothed? Or am I doing the opposite, hiding under the table? I'm distressed. I was separated from my parent. The door opens, the parent comes back, and the child looks at the parent. Instead of going there and reaching out, the child hides under the table or looks away and pretends, I'm fine, I'm playing. That is not secure attachment. That is, I've learned I better keep it cool and I better be self-reliant, because my help-seeking demand to the parent might actually cause the opposite of what I want. My parent might get aroused and more intrusive or abusive or withdrawn, right? So that's the experience, and you can kind of model that. And we know this from observations that that's how these different attachment patterns develop. Okay, so and then we also see that parenting at 7 months was linked to how the kids were doing at now 18 months. So the more you have of the good stuff, the more regulated you are now in your behavior as rated by the mother. So that's, of course, a caveat, because that's a maternal rating of her child's behavior. The CBCL is a very validated rating scale, but it's her own rating. But it's objective, observed parenting. What she did when she was 7 months in interaction with her baby predicts how the child is doing now at age 18 months. But, and that's there is some genetics that also kind of adds to the equation. This is just one example. So dopamine receptor 4. What is the dopamine receptor 4? It's our reward, novelty-seeking approach. Neurotransmitter, and therefore also gene that kind of regulates how much of that you have. You can see there is people have described in the literature a risk allele. It's when you have this, there's like a repeat area in the gene, and the longer this repeat is, there are like 2 repeats, 4 repeat. 4 repeat is the most common, 7 repeat. The more you have of those repeats, the longer is a protein sling that looks into the cell, and the less effective is this receptor. And dopamine transmission is less effective. So what you see is that if kids don't have this 7 carrier risk, whether the mom is low or high sensitive, it doesn't matter. They are just chilled out kids. They are not externalizing. It really matters in those kids where they have this additional genetic risk. If they are carriers, if the mom is low in sensitivity, then they are more problematic. They have more problems. So mom's parenting is important. It's more important for certain kids more than others. That's, again, no big news, but kind of it's nice to replicate that we find that as well. And that is, of course, that's why it's sometimes you feel like, gosh, you know, some kids are resilient and some are not in the context of difficulty. So then I want to briefly kind of just talk about something. I'm going to do 5 more minutes and then open it up for questions. Is what the moms is thinking is really important, and how this is impacting how she's then parenting. And I want to show you a little kind of, again, it's supposed to be fun, to show you that how we are, it's the music that plays in the background. It's what we grew up with. These representations that you as a baby learned, the attachment, security that you learned, that carries forward. As a grown-up, you have that then, and you trust other relationships, you are insightful, you are reflective, because that's what you learned based on those early experiences or not. And how was that? Who wants to be there now? And I think that this really illustrates, we are seeing the world different. And we see the world depending on the color, the music. We call it, so in the therapy that we work with, we call it, it's the music in the background that's playing all the time. We all have this music. This music is either lovely and sweet and you know, of course we all have our, you know, shark music. What we call it, the shark music. You know, it might be small. It might be on that given day, you know, you had a hard morning, running, you know, getting the kids off, and then you're stressed. But it might be small. It might be big. For people who had abuse, it's always big, and it's always on, and it's always blasting. It's full volume. And that's the difference. And that's why the perception of everything is colored by it. And so every interaction that you feel like, that was a good interaction. The provider, the OB, who says, this was a great, I did everything the best. But in the eyes of this person, it was different. And you might not even know how it was different if you don't ask. The issue is, if we don't ask, if we don't know where they are coming from, we will not know, we will not understand. So and so what we are doing a lot of that, we are getting these representational interviews because we want to understand in order to learn, in order to then have interventions that will change those distortions, because of course that is problematic. If you have these irrational, distorted perceptions, you see the world colored. So we can talk about it. Yes, your music is there. There is a reason why it's there, and yet it is in the way. Can we turn it down? Can we work with you to turn it down? Because not everybody is a perpetrator. The world is not easy, but not everything is always dangerous. But because you are seeing everything dangerous, sometimes you don't see the real danger, and then you are dating those who, pretend. Okay, so with that said, that also interferes with help-seeking behavior, because nobody is to be trusted. That makes it hard to be to do help-seeking. And so, on the other side, I did a qualitative study, kind of asking these moms, now, what do you want? Do you want services? Because many of these moms don't go to services. We refer them, they don't show up. And they tell us, yeah, we want them, but we want them safe, we want them nurturing, we want them comprehensive, we want medical and physical health together and mental health together. We want to feel empowered, we want to be treated differently. We want a whole family approach. So we have to change our healthcare systems. That's all. And so we have developed this intervention that's called Mom Power. It was developed with the moms, for the moms. They named it. They worked on the curriculum with us. After each iteration of this group, it's an individual therapy plus group, 13 weeks. We had retreats where we kind of asked them, how did it work? What worked, what didn't work? And it's a multimodal experiential. We watch a lot of videos, we talk, we have things that they do. But the whole point, what do we want to change? We want to change parenting sensitivity. We want to change these reflective capacities. We want to give them coping skills so that they can relax. And it has like multimodal. We want to enhance peer support, connect them to other services, practice in vivo parenting. It's based on attachment theory. Of course, it's very trauma informed. It's based in relational. So the whole concept, infant mental health, importance of early relationships, with some evidence-based skills that we teach. And we have some emerging data that it works. We had an open pilot on 99 women. We improved mental health. We improved their self-rated parenting skills. We improved their mental representations, their reflective capacity in interviews that were coded by blind coders. And we had with Medicaid match funding, a pilot RCT in the community, which was not easy to get off the ground, with community providers engaging in an RCT, where the wait list control had a chance afterwards to get the intervention as well. And we found the same thing. So we are very encouraged that this might be at least one of the many. It has to be a suite of services. We have now used the same model with other families who are trauma exposed and have a lot of disruptions in their life. These are military families, so families with young children, returning soldiers who went through a lot of trauma and now are facing parenthood and are feeling unprepared. And right now we are working on an iteration for fathers only, because one of the things that we learned, one of the sessions is bring your parenting partner. So some moms brought the father of the baby, if there was one in the picture. And then the father said, you know what about us? As usually you forget us. And so we said, no, we don't. We will work with you. And modify, but we have to really modify it in terms of the content and the delivery. So that's what's happening right now. Okay, so with that said, basically that's my message. Trauma alone is not potentially detrimental. It's together with psychopathology, with distorted cognitive schemas. It does impact parenting. It is modifiable. We can do treatments. Ongoing stress is, of course, totally detrimental. So if we can alleviate that, and how do we do this? By supporting, providing safety, giving resources, building skills, and trust building. Engagement, that's the key to even reach that population, because they don't come to us, to our beautiful outpatient clinics. We have to go to them. Okay, that's it. Thank you. I know I'm totally out of time, and I